We are live.
All right, thank you. Back from a short break, and we're going to continue looking at House bills that have come to us. And the next bill that we're looking at is H-153. And we have with us Representative Teresa Wood of House Human Services. Is that right?
Thank you, Madam Chair. Yes, I'm happy to be here.
Terrific. So Representative Wood, it would be helpful for you to give us an introduction to the bill. I think you were the reporter of the bill. And then after that, we'll have Jen Carby and Nolan Langwell talk, Jen go through the bill, and Nolan will look at the fiscal note a little bit. And then we'll again hear from DEVA, Commissioner Gustafson and Nissa James, and then Jill Mazza Olson, when she shows up, she's going to also give us a quick intro from her perspective.
Great.
Good.
You want me to go now?
Please
Madam Chair?
go,
Okay.
introduce yourself for the record and share your information.
Thank you. For the record, I'm Representative Teresa Wood, Vice Chair of the House Human Services Committee, and just wanted to thank the Senate committee here for taking a look at H-153. As you can see, H-153 is a relatively short bill, but it's a mighty bill, I like to say. It's short but mighty. This really has the potential to impact tens of thousands of Vermonters who receive services and supports from our home and community-based service providers each and every year. And who are those Vermonters that I speak of? They're people with developmental and intellectual disabilities, people with brain injuries, people with mental health issues, our older Vermonters, people with substance use disorders, and people with physical disabilities. There are people all over the state, in every part of the state, in every community in the state. And last year, members might recall, we passed H-611, which is the Older Vermonters Act, and your committee did great work on that. And you also may recall that there was a provision there about rate increases that was struck from the final bill. And so we're back at it in a different way. The one thing that I want to be very clear about is, as passed the House, this bill does not provide any automatic rate increases to anybody. And that I want to make very clear. So it does not provide any automatic increases. However, what it does do is something that is very important. It first builds upon the work that originated in the House back in 2017 and passed through the Senate and was adopted by the full legislative body. That was work that was essentially outlining that for the designated and specialized service agencies, that the Agency of Human Services had the obligation to review rates and set them based upon some certain parameters that you'll hear from Legislative Counsel when she goes through the bill. Well, the reality is that not a lot has happened in that area, frankly. And so we are building upon that work, and we are expanding it to the other home and community-based service providers. And who are those agencies, you might ask? They're folks like the home health agencies. They're people like the residential care providers, the adult day providers, the area agencies on aging, the traumatic brain injury providers. Those folks who, again, provide the fabric of the web of support that we have in our communities for people in need of services and support. So we are building upon the good work that you did in 2017 and adding to that group those providers that I just spoke of. And Ledge Council, again, will go through that. We are instructing the Agency of Human Services to promulgate rules that will implement those sections, since, in fact, there has not been a lot of action with regard to those areas that we passed in 2017. So as you know, that's sort of the legislative way of saying we really mean it. And we hope that that provision stays in. The other major aspect of this is the the providers that I spoke of in the definition of home and community-based service providers, right now, they're among a group of providers that really support some of the most vulnerable people in our state. And we have seen through this pandemic how they have risen to the challenge and also how they have been impacted by the challenges. We have lost 3 adult day providers, one in Washington County, one in Rutland, and the third one is escaping me where that is. But just the closure of those 3 providers has resulted in over 50 people being admitted to nursing homes as a result of having to leave their communities and their families because of the support that those providers had provided to families. And they just frankly had no financial reserves, despite the flexibility we were providing. They had no financial reserves to call upon in order to sustain themselves during this pandemic. And we have seen firsthand what that means for Vermonters. And now is the time that we need to start making some changes with regard to that web of support. So we asked the Department of Vermont Health Access, Division of Rate Setting, to develop a methodology for those services and supports, and to develop a rate setting methodology using an existing contractor that they have been using, Burns and Associates, which you may have heard about previously, for those services, and then for the Agency of Human Services on an annual basis to provide to the legislature information about what it would cost to meet what is, there's a definition in here, and I'm not pulling it off the top of my head, but essentially what it would cost to meet the challenges of providing those rates that have been determined by the Division of Rate Setting to be sufficient to provide services to the people that we're talking about. So it gives us the opportunity to evaluate, really for the first time, what it would cost to provide what are reasonable rates to this group of providers, for which we are asking them to do the state's work in supporting these individuals in the community. And they have never, ever had the opportunity to have that be presented to us as a body. So then it's up to us to make the decision, about whether we can afford to do it, or how much, or, to what extent. But right now, we are all familiar with the continuous advocacy on the part of these providers to try to eke out a 1% or a 2%, or whatever the cost of living percent that they might be able to eke out. And they, frankly, those COLAs really have no relationship to anything. We don't know if what we're providing is an adequate rate to provide services to the people that we're asking them to provide services to. So the ultimate goal of this bill will be to, again, put the information in our hands to be able to make the decision, and frankly, to ask the administration if they're not choosing to make a rate adjustment, why? And that's the impetus for this bill.
Listen, thank you so much. The work that you've done on this, I think, is really very important, and I'm pleased that you referenced the work that we did on the DAs and the SSAs a few years ago. That was a lot of work. I really I worked hard on that, and I'm glad that this is a continuation of that. I think it's really what I'm hearing you say is how critically important it is that providers are reimbursed appropriately for the care that they give to people who absolutely, I mean, in this case, you're not going to get it anywhere else. And so thank you. Thank you.
And I might add that these providers rely on Medicaid, for some of them, it's over 90% of the revenue that supports the services. They're almost exclusive, for some of them, are almost exclusively Medicaid providers. And so when we don't meet our obligations there, you can see what happens. The adult day programs, as I said, we had 3 folded, and just
Right.
when I was delivering on the bill, there was a residential care home who was closing its doors in Barry, and there were 24 people displaced. Again, in large part because we were not paying sufficient rates for Medicaid people who received Medicaid who lived there. So it is critical. It's absolutely critical.
Yeah, thank you. Questions for Representative Wood? Okay, so I'm going to ask Jill Olson. I know, Jill, that you have some scheduling issues this morning, and we haven't been through the bill yet, but I'd like to ask you if you think it might be helpful for you to offer some testimony before we go through the bill, or if your time allows for you to wait until after we've heard other testimony.
I appreciate the accommodation. I can wait. I have gotten off the conflict, so I'm actually now entirely yours. So we can go
Terrific.
through in your usual order.
Terrific.
But
All
thank
right.
you so much.
All right, thank you for that. Thanks for your accommodation as well. So Jen, why don't we go through H 153 so we can understand what's in the bill, and then we'll hear from Diva and JFO
Okay, great.
in reverse
this-
order.
This is H 153,
And you are?
and I'm Jennifer Carby, Legislative Counsel.
All right.
This is an act relating to Medicaid reimbursement rates for home and community-based service providers. So the first section of the bill adds a definition to the rate setting chapter. Excuse me. And it just changes some of the lead-in language first for the definition section, and then adds a new definition for use here of home and community-based services, which it says is long-term services and supports provided to older adults and adults with physical disabilities in a home or community setting other than a nursing home, including enhanced residential care services pursuant to the choices for care component of the Global Commitment Section 1115 Medicaid demonstration or a successor program. Home and community-based services also includes non-choices for care, home health and hospice services, adult day rehabilitation services, assistive community care services, and services for individuals with traumatic brain injury. So you'll see this is trying to focus more on the types of services and the populations that they're serving rather than identifying specifically each provider type. So that's the approach that they took here in trying to be appropriately inclusive. So this is home and community-based services for the purposes of this, this part. Again, it's the long-term services and supports for older adults and adults with physical disabilities in a home or community setting other than a nursing home. So choices for care and some non-choices for care, but otherwise similar type services. Section 2 adds a new section that is uses similar language to what had been added a few years ago for the designated and specialized service agencies. This directs the Secretary of Human Services to determine payment rates for providers of home and community-based services, using that definition we just saw, that are reasonable and adequate to achieve the required outcomes for the populations they serve. And when determining these rates, the Secretary must adjust the rate amounts to take into account factors that include the reasonable cost of any governmental mandate that has been enacted, adopted, or imposed by any state or federal authority, and a cost adjustment factor to reflect changes in reasonable costs of goods to and services of providers of home and community-based services, including those from inflation and labor market dynamics. When determining reasonable and adequate rates of payment for these providers, these home and community-based service providers, the Secretary may consider geographic differences in wages, benefits, housing, and real estate costs in each region of the state. So that's all similar to language that exists in the statute we'll look at next in the home and community-based service context. This is creating similar language for for the DA and SSA context. This is creating similar language for the home and community-based service context. And then, as Representative Wood said, it directs the Secretary to adopt rules that would set forth the methodology for determining the payment rates for these providers in accordance with this section. And it would have the rules include a process for determining an annual inflationary rate adjustment. They need to set forth a predictable timeline for redetermination of base rates, and they must use Vermont labor market rates and Vermont costs of operation. And then it directs the secretary to redetermine the payment rates for providers of home and community-based services in accordance with the section at least annually, and report those rates and the amounts necessary to fund them, so what it would take to fund them, to the committees of jurisdiction, including this committee and the appropriations committees and the human services, healthcare and human services committees on the House side, annually as part of the agency's budget presentation. So again, this would have the secretary come up with this methodology, adopt it through rules, annually calculate these rates, and determine how much it would cost to fund them, and provide all of that information to the committees of jurisdiction as part of their budget presentation.
So this would not allow for, would it allow for implementation of the rates? I mean, suppose I could think of a situation where it might be possible to go to implementation, but there's nothing here that allows for that to happen until and unless appropriations occur.
Right. I mean, appropriations would need to be
Yep.
made.
Regardless.
Yes. I mean, I suppose there would be nothing to prevent. I don't think there'd be anything to prevent the agency or DVA from increasing provider rates based on their existing appropriations.
Right. That's what I was thinking. So we can ask DVA about that
Okay.
going forward.
I mean, I don't see anything in this or an existing law that limits their ability
prevent
to change, but it generally takes more money, and that's where the legislature comes in.
Okay.
So instead of telling them that originally in an earlier iteration of the bill, I think what passed the Human Services Committee, but was modified in the Appropriations Committee, would have kind of had this be part of the budget proposal. So built in when the agency came to the legislature. So sort of a half step further. It would still require the legislature to agree and appropriate that amount, but this is a little bit more of a step back and just providing that information. But as Representative Wood said, it gives then the opportunity for the administration and the legislature to understand what it would cost to get to the rates that were determined to be appropriate. And then make choices. The legislature could make the choices about whether to spend it. Section 3 makes changes to that existing statute I was mentioning around the designated and specialized service agencies. And so it first kind of lines it up with the language in the prior section for the existing provisions, and adds the new pieces around the rulemaking and the annual calculation. So again, the Secretary of Human Services shall determine, and in this case, it's the Departments of Health, Mental Health, and DAIL's rates of payments for the designated and specialized service agencies, the DAs and SSAs, that are reasonable and adequate to achieve the required outcomes for the designated populations. And when determining these rates of payment, the Secretary would adjust the rate amounts to take into account factors that include the reasonable costs of governmental mandates, and a cost adjustment factor to reflect changes in reasonable costs of goods to and services of the DAs and SSAs. And similar change here, when determining reasonable and adequate rates of payment, the Secretary may consider geographic differences in each region of the state. And then we have the new language where the Secretary would adopt these same kind of rules, setting forth the methodology for determining the payment rates for services provided by DAs and SSAs to individuals with mental conditions, individuals with substance use disorders, and individuals with developmental or intellectual disabilities in accordance with this section. And the rules would include a process for determining the annual inflationary rate adjustment, set forth the predictable timeline for redetermination of base rates, and use Vermont labor market rates and Vermont costs of operation.
So let me go. I want to jump back to to, I think it's C, wait, no, it is B. Yeah. So it adjusts based on regional differences, and there is no indication of the data that's being utilized for that determination. And yet we know that we do get from, help me, is it ACCD that puts out regional economic differences, based on median income and cost of living, say for a difference between Chittenden County and Orleans County. And I know that that data comes out, and it's somewhat surprising as to the, so I don't, but I guess just the question is, was there a discussion about, in this context, about which economic data was informing this?
No, I mean, some of this is existing language,
it
although
is.
as Representative Wood said, it does not appear to have been utilized to this
Nope.
point. But it's permissive. The secretary may consider geographic differences, and down in subsection C, the rules shall use Vermont labor market rates and Vermont costs of operation, but it does not identify the specific source in here. It may identify as part of the rulemaking process, and that may be something that the public or stakeholders provide comment on when the secretary is developing the rules, but there's nothing in here that specifies the source.
Okay, thank you.
And then subsection D, again, is similar to subsection D in the previous section, where it requires secretary to redetermine the payment rates for the DAs and SSAs in accordance with this section at least annually, and report those rates and the amounts necessary to fund them to the committees of jurisdiction annually as part of the agency's budget presentation. So again, this provides you the information, and then the legislature ultimately makes the appropriation decisions. Section 4 has DEVA doing a report. So on a rate study and a report, DEVA, in collaboration with Dale, the Department of Health, and the Department of Mental Health, is directed to conduct a rate study of the Medicaid reimbursement rates paid to providers of home and community-based services. And that definition we looked at in section 1, and providers of substance use disorder treatment services, including their adequacy and the methodologies underlying the rates. And as Representative Wood may have mentioned, it sounded like this had already been done for the DAs and SSAs other than the substance use disorder treatment services. So that's why they are not otherwise specifically included in here. As part of the
that was the 2017 stuff she was talking about.
As part of the rate study, DEVA must do a few things: delineate a reasonable and predictable schedule for Medicaid rates and rate updates, identify ways to align Medicaid reimbursement methodologies and rates for providers of home and community-based services with those of other payers to the extent such other methodologies and rates exist, and determine ways to limit the number of methodological exceptions. And this rate study would be done over the rest of this year, with the results on or before January 15th of 2022 being reported to the committees of jurisdiction. So the results of the rate study and the findings and recommendations coming, including this committee, and also to the Secretary of Human Services, the expectation that that may inform some of the rulemaking and calculation processes that are required. And can we just hit the effective date and then be done?
Do it.
All right. So the act would take effect on passage with the rules adopted by the secretary under sections 2 and 3 around those rate determinations taking effect on or before July 1st, 2022.
Okay. All right. Why don't we, I guess we can take it down unless someone wants to go back to it. I guess my question is on, we'll find out as we go along, but in terms of the alignment with private insurers, because obviously private insurers also support these services. And I saw there was some language on that alignment, but does it make sense? So maybe it makes sense to look at the role of DFR or Green Mountain Care Board in that work.
I mean, I think it's looking for ways to align the reimbursement methodologies and rates. So in general, this is reimbursement amounts, which is not, as you know, as we've discussed in this committee, has not historically been something that has been within DFR's jurisdiction or something that the Green Mountain Care Board has had a lot of involvement in. So, and DVA may have thoughts on that since they're the ones being directed to do this work, but they're already consulting with a number of state agencies.
Okay, yes, though we did ask Green Mountain Care Board previously, and now we've asked them again to evaluate some of the budgets for our DAs and SSAs, and we're getting
Right, that's actually an ongoing duty that you added
Yep.
last year. It's sort of a limited scope, but ongoing budget review.
Yeah, so just trying to see where the gaps are and what the needs are. So, yeah, all right, Senator Cummings.
This may be just spleen venting from a money chair, but this sounds like a lot of work that we're going to ask agencies to do. And time is money. If they're doing this, they're not doing something else. It will be good information to have, but the bottom line is the appropriations committees know that we are not adequately funding these services. Senator Kitchell has a list of promises not kept. Unless we know where we're going to get additional money, I mean, there's a certain public shaming that goes on that says you should be doing this. We're looking at the pension and salaries have been eating up all the increase in revenues for the last, I think, decade. And now we have another pension crisis. I hesitate to ask people to do work unless we think there's a reasonable solution to the problem they're going to identify. I mean, I worked at one of these adult days 20 years ago. We were not paying enough to keep them open. It was all hand to mouth. And we know our, home health agencies are all living off their fundraising, not the money that they get from their Medicaid rates. But unless we know where the money's coming from, I don't know. I mean, it's nice, but is this what we want people to be doing?
So that's exactly why we sent the budget evaluation to Green Mountain Care Board for DAs and SSAs, so we could understand the whole budget piece. There's some perhaps reluctance on the part of certain organizations to share all of their income. So it's important that we get the full pictures. Having said that, there is a bit of frustration, Senator, going forward and looking backwards when we know that this is an ongoing lack of funding. And it's not just when you think about it, it's an organization, but it's the workforce that is there, the LPNs, the RNs, and the social workers and others who are also underpaid. So we're going to have to hear from DVA, and then we'll hear from DVA, and then we'll hear from Jill Olson. We're going to have to begin. I didn't mean to jump over Nolan. I didn't jump over you. Coming to you, so we can get an understanding of what's here and the implications of what the bill is asking for. All right, Senator Cummings, thank you for your comments. Nolan, did you want to add in anything regarding fiscal note on this?
Sure. For the record, Nolan Langwell, the Joint Fiscal Office. I'll be really quick. The three things I'll point out are: one, that the bill does not have an appropriation. Two, I did do some analyses, and based on the information that I looked at, I estimated that for every 1% increase in these particular rates for these specific services that Representative Wood has sort of clarified in her testimony, every 1% would be approximately $4.5 million gross, or about $2 million in general fund, and that's in the fiscal note. And then the last thing I'll just comment on, and I'll let Nissa or Corey follow up, is that for the rate setting study, they did say that they would have some one-time contractual needs, and that they'd also need some FTEs to do some of this work, but there's no money in the bill for that. And I'll let them follow up on that. But that stuff's all in my fiscal note. But I also did say, to the extent that any of that work is not funded in the big bill, that DEVA would come back and ask for it in budget adjustment. So I'll just leave it at that unless people have questions.
Okay, thank you. And we'll probably get back to the fiscal note as we're become more familiar with the bill. Thank you. All right, so let's hear from Corey Gustafson and Nissa James on H153. So thank you again for being here.
Long time no see. Good morning, Corey Gustafson, Commissioner, Department of Vermont Health Access. So we were actually just going to talk about the actual piece that Nolan was mentioning, but I think it's kind of been referenced here. And this committee has not had the, well, I don't know if it would be a pleasure, but the time spent with DEVA to talk about, our budget and our annual report, essentially about what our goals are, our priorities. One of those is payment reimbursement. We characterize it as value-based purchasing as as one of our three primary goals. So we have reimbursement goals and have essentially a structured approach to how we reimburse. So I have to just kind of note that.
I don't want to interrupt your flow at all, but I will say that is one of the things that we are going to ask you to come in to committee to present.
Okay. Yeah. It just is kind of relevant here, and so I'll truncate it a little bit. Like I said, I don't have a flow either. This conversation reminds me of what we haven't been able to discuss. We want to be a reliable partner. We continue to professionalize Medicaid reimbursement methodologies. We want to efficiently allocate the resources that we have. That's the comment that Senator Cummings was making, to ensure cost-effective care for Medicaid members, given the finite resources that we have. We have, in that goal of being a good partner as far as reimbursements go, we look to professionalize our reimbursements, which means establishing a predictable schedule for fees and rate updates, aligning with other payer methodologies, and limiting the number of methodological exceptions. That's where that language, I would assume, kind of comes from, is that our process that's in place is very much that which I think is being asked for. So that really resonates with us. We appreciate that this is the path it's going when we get called into committees to talk about an X amount of increase that needs to happen in a particular service line. We often go to, we are in this, we have adopted this process and continue to evolve it of professionalizing our reimbursement. So there's nothing in this bill that I would say contradicts any of our strategies and goals of being remember I said reliable and predictable payer. I don't know that necessarily promises that we can be given our resources as a state. It's not DEVA. We don't have any money. We deliver the money, right? So for the services for eligible members. So being reliable and predictable makes things better though for our provider community, because it doesn't become who's the most effective, let's say, in a committee room, et cetera. So again, trying to make that point that we want to be a part of any of this work. I will say that we have done this work in the DIVA, and so don't take that to wait for the rest of that. We have done that work in the DIVA long-term supports and services, HCBS rates that we maintain. We have done this work. I think Jill will probably tell you in the DIVA paid home health services, we've come to an agreement about a methodology and plan to have an annual review. We just did in 19, the end of 19, and justice may be a wrong word now that we've been through the pandemic, and that's ages ago, but we have done increases in the areas that we have oversight. So I think a lot of this work is in reimbursement areas that fall to our sister aid departments. And we're willing to do that work for sure. We do have that sort of experience. We'll say that as to color Nolan's comment a little bit of like why we need to have contractual funding and personnel is to, again, to refer a little bit to our annual report. We have, well, I have in front of me 1, 2, 3, 4, 5, 6, 7, 8, 9 payment reform projects underway. That leaves out our reimbursement reviews that we need to do on an annual basis, or semi-annual, or or sometimes quarterly. But this is the team that would take this work. We are completely stretched, and in fact, I'm not mentioning the 1, 2, 3, 4, 5 projects that have been brought to us by our sister departments or other parts of the agency to say, hey, I see what you're doing in, and I'll name some now. I see what you're doing in the mental health payment reform. That one's underway. Residential SUD payment reform, applied behavior analysis, developmental disability services, children's integrated services, high-tech nursing, DOC, transitional housing and success beyond 6. We are doing work in the reimbursement and value-based purchasing area on all of these with it's about a team of 5, but it is not a team of 5 right now. It's a team of 4. We also have some future parental leaves coming at us. We have currently a parental leave. Our lead, Alicia Cooper, is right now out on parental leave with a happy and healthy baby boy. And so we are asking for the personnel, especially given that there's an urgency to the work getting done. So we have no problem. We just don't have the resources. On the contract, that our existing contract, we contract for the work that we have to do. We don't have just space in those contracts to be utilized otherwise. I appreciate that in the end, there was at least a recognition from in the bill that we could come back at BAA, but I've been told many times that's not the way that we should do things. So I'll just raise that as, I think that if we are going to do this, which we're happy to do, and look at these rates in other parts of the agency, and we need to put this report together, we should really consider putting dollars towards the work. It's a good project. I will say on, the other one, the ACCS, that was kind of an orphan code. We have a project now that is beyond just long-term supports and services, but in that, the ACCS, in 2019, it was brought to our attention that code had not been that rate had not been adjusted for a long period of time.
Can you define that
Go ahead.
acronym, please? Yep.
Oh yeah, assistive community care services.
I'm sorry.
Assistive
Yep.
community care services.
Got it.
And so with the legislature, it was a conversation. We said, let's raise, I think it was a $5 per day increase to those rates in mid 2019. So for FY 2020, but continues to be a challenge. We're actually have prioritized looking at the methodology, and that was starting, has already started. I think it got pushed back a little bit because of the pandemic. But we just completed the home health services portion. So I guess I'm just saying we have an awareness of these orphan codes, and I think that what's behind this bill generally is a really good idea, because we don't want orphan codes. That's why I bring it up. You get orphan codes if you wait until someone comes and says our rate's way behind, and then you end up we go through in Human Services, Healthcare, House Approps, Senate Health and Welfare, and into appropriations, and it just becomes sort of a horse trading activity. And instead, I'd rather have it be professionalized. So I really appreciate the work of this bill. It hasn't been in our purview before. We're glad to have be asked to do it. We just need the resources. I think I might have stepped on pretty much everything Nissa was going to say again, but I would pause to see if she has more details.
Thank you, Commissioner. For the record, Nissa James, Department of Vermont Health Access. So the Commissioner did a great job of describing the reimbursement goals for that have been established for the department, and specifically around professionalizing reimbursements. Related to that, for the newer committee members, as this is likely information that the existing committee members had, if you remember back to pre-COVID-19 public health emergency, Dr. Cooper was discussing the plan for establishing methodologies and predictable schedules for updates as she had identified. And before the public health emergency, that really focused on the DVHA paid home health services, and then prioritizing as the next services for assessment, the assistive community care services. Fast forwarding a year, what I can share is that the team has a methodology developed with mutual agreement by stakeholders for the DVHA paid home health services, and the proposed effective date for that newly developed methodology is January 1st of 2022. I mention this because this work has encompassed a lot of participation by not only provider association representatives, of which there is one on the witness list for today, and so I would defer to her about what participation in that process has demanded of her time, but also because the work completed by the team to date has accomplished many of the goals for these specific services, as it's indicated in the H-153 as passed by the House. If the tremendous scope of work related to the rate study as passed by the House moves forward, I do have concerns that it could potentially impact our ability to implement the work that has been completed to date for the home health services. And it's really due to capacity, and that is part of the reason why the department requested additional limited service positions to support the work that was required and contractual resources. And we can get into the specifics of that in a little bit. And then for the next set of services that was prioritized to be reviewed, it is assistive community care services, but also enhanced residential care services, which fall within the Department of Disabilities, Aging, and Independent Living's budget. And so that really gets to the commissioner's emphasis on the fact that while DVHA is happy to engage and complete this work, many of the services, as indicated in the bill, fall outside of DVHA's jurisdiction. And so they are within our sister departments within the agency. So to that end, I would be happy to share some more specific information on what the impact for our department would be, if that would be helpful, particularly as it relates to the work required to complete the rate study as passed by the House for not only the choices for care services, but also the mental health services and the substance use disorder services. So Chair Lyons, would you like me to continue?
So what I think is we have 10 minutes left, and it sounds like it's going to be a longer presentation. So what I think we should do is to move to Jill Olson, who is here representing the providers, And then I think it will probably make sense to schedule you to come in another time if that works. Can we do that with
Of
you?
course.
Yeah, and because I think there may be a lot of questions that are being generated as we're hearing from you and from Commissioner Gustafson. And it also might be helpful to have this presentation concurrent with or after the your planning process, DEVA reimbursement plan that's going on in place, just to get the full picture. So yeah, I really appreciate the time that you've given and would look forward. I actually look forward to your presentation.
Thank you.
Okay. So Jill, thank you for being here and your information. You've heard the discussion, and I know you've been involved with this in the House, but we need to get kind of the bigger picture from you, from the providers, and then the importance of this particular bill and how you're looking at it.
Okay. Thank you so much for having me. I'm Jill Olson, and I am the Executive Director of the VNAs of Vermont, representing home health and hospice. And I do just want to clarify, today I'm only representing home health and hospice. So I think my what I say will probably resonate with many providers, but I'm only representing home health and hospice today.
And listen, we have others to invite in. For example, Janet Hunt is here from the 4As, and we'll have her come back in with testimony.
Okay.
Yeah, good.
Yeah, I just wanted to make sure that was clear.
No, it's clear.
Yeah. Okay. So I've been listening to your testimony. I have some things that were definitely on my list to say. As always, I'm sort of adjusting based on what I've heard. So first, I want to thank Representative Wood for championing this issue. We really are deeply concerned about the Choices for Care program in particular and its sustainability. And we were fragile heading into the pandemic, particularly our workforce, and we are fragile coming out of the pandemic. So it's a substantial issue, and one that I think we really need to grapple with as a state to make sure that older and disabled Vermonters are able to stay independent at home. That's what that program does, and we're having trouble making it happen. That's the reality. I also want to thank Commissioner Gustafson. I think he talked a little bit about his efforts under his leadership really to professionalize rates. And so on the home health side, and remember, we do home health, hospice, and long-term care. So home health and hospice are paid for by DEVA. Choices for Care is under DAIL. So I just want to be clear that there are three different things. So hospice is actually pretty well taken care of because there's a federal mandate that the Medicare rates will be reflected in Medicaid rates in the state. It's the only service that we do that has that linkage. So the efforts on professionalizing rates have centered on home health, the clinical home health services, so nursing care, therapy at home, and that has been a really productive and really a solid process with DEVA, and we really appreciate it. And I just want to say it is a lot of work. So I support that DEVA feels like they might need some more help in order to get all of this done. But I would say I think it's important to do this work because right now it feels as though it's really hard to get anyone to understand the extent to which this program is underwater. Choices for Care is underwater, and we work pretty hard every year to try to get attention to it. But I would like to see some more structure to that effort. So just a couple of things to share with you about how we know that Choices for Care is in trouble. So we did a study about back in 2019 to see how far off our reimbursement was from our costs. And it looks like we're spending, back in 2019, we were spending about 27% more to provide the service than we were getting paid. That was before you raised the minimum wage. And there was no rate bump for the minimum wage increase. So some other providers actually saw some dedicated rate increases to try to get them closer to $14 or $15 an hour. We have never seen that. I have many members who have stretched to $15 an hour in order to compete with other employers. but without real support from the budget. And so that's how we get to being so far underwater in terms of the funding for the program. It's really not sustainable. And I think the evidence of the fact that the funding isn't working is that we have about 1 in 4 PCA positions vacant today. So 1 in 4 positions that we need in order to take care of people in their homes, we don't have that person. And it's really hard work. And it's there is easier work that people can do for the rates that we're able to pay. So we have dedicated folks who do this work, but it's really challenging, and a pandemic made it that much harder. So the need is really great. I'm sorry, back to the home health rate setting piece. The advantage we've had on that is that we do have a Medicare fee schedule that we can compare the home health Medicaid fee schedule to. So there's kind of a ready-made methodology. I think that's not quite as obvious for some of these other home and community-based services. So we were able to make, I think, faster progress on home health than we might have otherwise because of that. I think those are, I guess the last thing I'll say is that, Choices for Care is a relatively straightforward and simple program. We provide the service at home. So there aren't facilities, there isn't equipment, there isn't a whole lot of, sort of other stuff. We pay for the people, the miles they drive, and then the provider tax that we pay. Those are our primary expenses in pretty much across all of our programs. So it's not mysterious in any way. It's quite clear. We're paying people more than we're getting paid, and because we're trying to provide a critical service in Vermont. So I'll leave it there for questions.
Go ahead, Senator Hardy. Thank you, Jill.
Mm-hmm.
Thanks, Jill. Just a quick clarifying question. You mentioned 27%. Could you just go over that stat again? 27%
Oh, sure.
Of what?
Oh, sure. So our costs are 27% higher than our payments.
Got it. Okay. Thanks.
So another way of looking at it is they receive 75% of what they need.
Right. That's right. That's an easier way to say it.
Well,
Let me write that down.
but no, but 75% sounds so much better. It sounds more optimistic, but 27%. Yeah, loss, really. It's a loss.
It's a 27% loss ratio, but that's an even worse term. So, right.
Senator Hooker.
Yes, thank you. Jill, what percentage of your services does Choices for Care comprise?
I would say, so it depends on the agency. So Medicare is about 60% of our revenue, and Medicaid is about 28% of our revenue. About half of that is Choices for Care and half of it is Medicaid, but it really depends on the agency. So some agencies have very large Choices for Care programs, and essentially the agencies that have more trouble keeping a bottom line are the ones that are providing more Medicaid services. It's pretty clear when you look at their payer mixes.
Okay.
Yeah, I don't have it by patient. There are different ways to look at it. I can certainly get you more data if you need it.
Does that imply? Does that imply that the other 12% is private?
There's about 10%. Yeah, it's maybe 10% at the most.
Okay.
Like I said, it's different by agency, but that's about the overall. Yeah, commercial payers are pretty small for home health, and there's really nothing that's a commercial. There's not really much commercial coverage for long-term care.
Okay. Other questions? So obviously we have, thank you, Teresa. Thank you, Representative Wood, and for sticking with us. And we may be back in touch as we go forward. Greatly appreciate your time. We have a lot of sort of work to do on this bill, and we need to hear from others. I know Janet Hunt, you are here, and we thank you for being here. We'll have you back in. As you can see, this is our first introduction to the bill, and so we have a bit of a ways to go on this one, I think.
Great. I'll be happy to come back. Thank you.
Thank you. Okay, and we'll also have Diva back in. um, to talk about the bill. Committee, we've gone through three bills today. Let me know as you're thinking about the bills. I think some are probably have less of a heavy lift than others. So we'll try to put those into the hopper so we can get some of this work done going forward. So that is it for today. Thank you. It's been a lot of work. Appreciate the time. And Jen, you've heard some comments for some changes, and I think we've sent people out of the room to do some work a little bit. And then we're also going to hear back. I think we definitely need to hear back from Diva on the last bill and from the providers, so we can fully understand what we need to do. Okay. We're so good, but we're late.